good. So this is very much so a team effort. So Jodi and Amy are going to step in and redirect where they have something to add, or I might be going off course. But a little background for this. So the D&I Program Consulting Service, IHQSC, which is the Institute for Healthcare Quality, Safety, and Efficiency, submitted a request to the D&I program wanting some information and some help. And so what they were really looking for and how they framed it, or at least where we got to at the end of the call with Jodi's help, was they really want to develop an algorithm or some sort of method to help predict the success of QI projects that they support. So some additional questions to kind of help to keep in the back of your mind as we provide a little bit more context. So what types of frameworks and approaches might guide them in this effort of predicting the likelihood of a success of programs or projects? And what do you think about the overall concept of a prediction generator to predict the success of these projects? So for those of you that aren't familiar with IHQSC, it is a quality improvement training program here on campus. It is about a year-long training program, and they do a lot of different things, but we're really focusing on the training of clinical operational teams. So what happens is dyads or triads of clinical operations folks put together a QI project, and they apply to be part of this year-long training program. And then IHQSC faculty and leadership vet the different programs that apply each year. Those programs and teams that do apply, they participate in a didactic component along with a really application-based training aspect, which is where they receive intensive coaching from one of the QI experts to help them optimize and conduct their QI project. And so IHQSC is really prioritizing projects, and they want to invest in those projects that improve value for the health system. So thinking about cost and effectiveness, things that matter to the C-suite is, I guess, how I would say it. And they want to really focus on projects that are not only an N of one and demonstrate short-term impact, but ideally that builds capacity and that are sustained over time. They admit that they really don't have much in terms of D&I science background, but they've heard about it, and they think that there's a way that they could leverage it to boost the caliber of the programs and teams that they support, and their overall training program in general. And they really have, they've scoured the D&I literature themselves, but they want help sifting through it to identify frameworks and approaches that they can use. First and foremost, now they'd like help in order to predict the success of the different programs that they're vetting in the application process. And then maybe perhaps in the future, they'd like help identifying frameworks and approaches that they can work with the individual QI teams to inform and guide their individual QI projects. But really the specific ask right now is, how do they identify those projects and those teams that are most likely to be successful? So with that, I'm going to turn it over to you, Jodi.
Sure. So we had this meeting for an hour, and we had this discussion with them, and their first point was we wanted to make sure we weren't missing anything. So they really wanted to be able to say, we assess these things, we can put it into this formula, and it'll kind of spit out for us like, well, this will be a successful project or not. And so we asked them, well, tell us a little bit about the outcomes of these various projects. Are they the same outcomes, or are they all different? And they said, no, they set what their outcomes are that they're looking for. So each project that comes to this group has different outcomes. So we're dealing with different projects that are trying to accomplish different things with different outcomes, with different teams in different places. But they want to get a sense, are there elements that will help them to discern these things? And so they really wanted to know, like, is there something that exists to do this already? And Amy and Katy and I went, well, there's lots of like frameworks and surveys and things like that, but we're not aware of something that does this exact thing. So that's our first question for the group. And I'm also going to start off with inviting Amy to provide any input of anything that Katy and I missed in the big picture summary. But we would like to have a discussion with this group for the next, 30 minutes or so, or whatever amount of time we have. Where do we go with this? Are there scales or surveys that exist already? Are there theories, models, or frameworks that we can use to help structure asking these questions? And if yes, what and how would it work? I see there's an item in the chat. So let's see what that says.
Just a clarifying question, is this a research project they're doing?
No, they simply want, if you were this group, different quality improvement projects come to them. And I think what I took from what they were saying, we maybe have more projects than we can work with. And so how do we discern the ones that are going to be most likely to be successful in accomplishing their goals? Does that make sense? It's not a research project. They're QI people, and they want to make sure that their QI projects both let me just say one more thing. I remember seeing an article in the D&I science community years ago, like maybe 3 to 5 years ago, that basically the authors were saying, we should focus our research efforts in places where there's a greater chance of success, rather than spending time on the really, really hard cases. And focus where like we have a better hope of it going well. So it's a similar kind of concept.
And who funds this group? Is it university or is it hospital in terms of context?
My understanding.
Go
ahead, Jodi.
No, go ahead. You know more about this group than I do.
My understanding is that initially, so this has been a program for a number of years, it was supported by the hospital somewhere. But when I was looking at their website, which Hillary put in the chat, it actually costs the teams money now. So I think upwards to close to $8,000 to participate. So I think it's by users.
And I think a recent development is that they are moving outside of the University of Colorado and recruiting teams outside our university, which I think is part of the impetus for this. I think they used to focus on developing teams that they hope stayed at CU, and whether their first project was successful wasn't as big of a deal because they developed the skills to move on to other projects that were successful and continue to work together as a team. But now they're focused more on the project and less on the team as they move outside of the university. And I think the other important thing is they want to be able to make this prediction before the team has gotten started. So the team may not know the answers to some of the framework domains, right? Because they haven't done any investigation to know those things at the beginning.
So I see Mustafa made a comment at the beginning. My first impression is that CFR constructs can be used as a starting point to create a checklist to predict success. So that would take us in one direction as we pick a TMF, a theory, model, or framework, and say, here's a structure, here's an organizing structure in which we might pick from that a series of questions to ask these groups as they enter asking for help from us, if I'm IHQSC, to say, do you have these things in place? And then utilizing that for the decision making. And so you could pick something like CFR. Why did your mind go to CFR, Mustafa, instead of something else?
That's one I'm relatively more familiar with. Otherwise, any comprehensive model that shows like what needs to be included in for the success of implementation. So basically it's very it will be very superficial probably, though, like let's say internal settings being considered, yes, no, like and also as well as sub-components of internal settings or the other things have considered, yes, no, and you can add them up, which is what is considered, what is not considered, so they can give you some kind of prediction, but like the accuracy will be problematic. So and I entered another thing, so I said I think the best approach would be like there can be a prediction in the beginning, but this prediction can be revised as implementation starts. So probably, and this actually probably for example, sustainability can be predicted. So that can be probably easier to predict. So it can be a better starting point. So whether this project will be sustainable or not, rather than successful or not.
Dan, just to see your question in the chat, how do they define success? So we asked them, and they said that they define, what I remember, jump in and help me, but that each project comes in with their own outcomes for success, and it's whether they achieve those outcomes. So each project, it's going to be this moving target. So it's not like the same thing for every project. So this,
I think that makes it hard then to kind of, because you're comparing oranges to apples. You know, if somebody's designing a project to increase adoption or sustainability, it's going to be different than if something's going to maximize effectiveness in some clinical setting. You know, it's just, I'm not sure they're ever going to be, I'm not sure they're ever going to be comparable in this way. I mean, after the work we've done trying to predict which LVAD programs are more likely to adopt, and at least in our first pass of the analysis, all these questions on how do you think you're going to do don't seem to predict. We're looking at it again, so don't run with that. But it's really hard to predict ahead of time who's going to succeed. You know, and I don't know, it's just by their outcomes, the things you want to know, have they engaged all the stakeholders? How does the team work together? You know, some of these other kinds of things that are going to be really hard data to gather about a project team.
I noticed that they have a very big number of faculty and staff, maybe over 15 to 20, and they're probably highly interprofessional. There are a number of concepts that we routinely think through that they may not. Bethany mentioned penetration. I was also thinking, Dan just mentioned stakeholder engagement. I was thinking about sustainability. And we know that there are tools, imperfect tools, but there are some measurement tools for these things. So you could suggest to them a process where there are some outcomes, sustainability, penetration, stakeholder engagement, some qualities that might be a measure of success, and they could work across each of them. They could do some sort of ranking process or engagement process across themselves of what they want, and then they could message that to their applicants.
do you think though that across, Hillary put in the chat here the link to the 2020 IHQSC project outcomes. So you can see that the outcomes are kind of all over the place in terms of reducing inappropriate PT consults and weaning people off, or pediatric ICU sedation weaning. And, you know, there's all these different kind of outcomes for patients. Are there core success indicators that are always there, like necessary things that no matter what they're trying to achieve, if you don't have those things, it's not going to get you to your outcomes. So this is where my mind goes to, like, kind of what are the necessary and sufficient ingredients to using a simplistic, like, say you're going to make chicken noodle soup versus tomato soup versus, whatever, you still need certain ingredients. You need some kind of liquid and you need some kind of, whatever. So my mind goes towards, like, are there certain things, like they need a leader for the initiative who has sufficient experience. They need to have enough resources and knowledge to make this thing go, like, yeah. So the sustainability plan, like, I mean, I'm wondering if you had to add one question, would be, if at the end of this is all over and it works, will it continue? It's kind of like my main question. But like data leadership, are there things like that that would help them think through this?
I thought it was interesting, Jodi, when we were talking to them, that they rattled off some of those same things. They've already sort of figured that out on their own after going through lots and lots of projects. I think maybe they needed some validation that we agreed.
So I'm not hearing anyone's mind jump immediately to, oh, there's this scale they should use, or there's this combination of scales they should use, or here's a theory model or framework that will provide the overall structure for all of this that they just need to start with. Is anybody going there with any of those things?
Well, so Jodi, I joined like 5 minutes late and you were already so deep into this, but they're trying to build some sort of an algorithm to predict. Is that right?
They didn't use those words. They said they wanted some kind of, like, prediction generator. Maybe we can go to the next slide, because this is the second part that we could have to our discussion, is what do you think about the overall concept of a prediction generator? They were kind of like, how can we know before we start which projects will be successful in accomplishing their own self-identified aims? What, yeah.
Did you do a pilot? I mean, that's one thing, do a small
Well, that's
scale
what they
pilot.
are doing, is they're.
It seems more like a process they need to follow rather than, if this particular set of factors are present, then you are sure to be successful. And more, did you engage your stakeholders? Did you identify that this is in fact a need that exists within this clinical context? Do people care about this problem? And are there people willing to work on it? And then did you test it out in a pilot? That's what I would recommend. That.
And I think actually that's probably their strength. They do lots of process with QI. And I wonder if with, their 8 years of experience of these processes, now they're looking at their overall impact, and
It's not very high. They
yeah,
said.
they're not, yeah.
So how
Despite
can
good
you,
processes. I mean, I think they do
I
have.
mean, imagine the metaphor of racehorses and which ones you're going to bet on. You have 10 horses in the race and you can only bet on 5. What are the criteria by which you're going to pick the 5 that you're going to bet on? I think that's essentially kind of the question they're asking. Where do we put our resources towards those who are going to be more likely to be successful? Because we're spending a lot of time spinning our wheels with a lot of projects that don't really have successful outcomes.
And did you have a chance to talk with them about, since a number of them haven't either succeeded or sustained, about their perception of why? And I'm just wondering, was it they never got off the ground? They generated conflict. They were initially successful, but not sustained, or all of the above in different things? Do you have any sense of that?
I don't think we talked about all of that. We didn't have a chance to get into all of that.
I think your racehorse analogy is excellent because it also kind of gets us into like the expanded consort diagram and bias. So, there are millions of horses that don't get to be racehorses. There are lots and lots of QI projects that don't get to move the needle. And really, the needle is hard to move. So I think they feel frustrated, and yet the needle is hard to move, especially, and several of us, and then not me, but others, have millions of dollars and the needle doesn't move. These projects don't have, generally, I don't know that these projects are funded. In fact, you have to pay to play. So, I mean, the fact that these are like really great QI projects in some ways.
We did this thing with our Jerry Fellows. We only did it for 1 year. But we had them organize their QI projects around the re-aim outcomes. And, because a lot of people just think about, could this increase effectiveness? And just even having all of their applications that come in say, what does this do to hit reach? What does it do to increase adoption? What do you do to support implementation? What do you think you need? And just having them answer those questions as they come in, so that as part of their review of projects, they could then at least compare a little bit of apples to apples in terms of the outcomes, rather than letting them define their outcomes, because pretty much any outcome they define would fit into one of those 5 categories. And so then they could at least compare them in that way. And as a committee say, this one may be less effective, but wow, it will reach every patient in Colorado Springs and Fort Collins. And so maybe this is when we need to invest, and we need to define our outcome by reach. And engage with them. We only did that. We didn't do it with the fellows for very long. I don't know why. Didn't really ask either. But I don't know. It's at least an idea so that they're not trying to compare that way. And then using a framework, and re-aim is so accessible to sort of the non-researcher. I'm not trying to make Russ feel proud. I'm really not. But it is so accessible. It's one of the things we all love about it. And I don't know, just an idea. But I think the question you're asking, I'm still just struck, is just, there's not going to be one measure that's going to say this team's going to be better than this. I just can't believe that would be the case. Because
I think there might be some things that might be useful for them, in the sense that, so I've been doing QCA for a while, and QCA looks at, if you have an implementation outcome, what makes for successful implementation. And so you look across projects, and certain things always kind of end up there, that, okay, we've got these 20 practices, and the intervention happened and got off the ground and achieved some outcomes in these 10 and not these other 10. What was it about the 10, that made whatever it was that you were trying to have happen? It's things like leadership, a key person whose time it is that's devoted to that to make it happen. It's knowing how to make things happen. Like it's, the knowledge of doing it. Like there are some big rocks in the jar that, like, if they're not there, it's not going to happen. Like, if none of the clinicians know how to deliver weight management in my study of weight management in primary care, it's not going to happen, because nobody knows what they're doing. Nobody is taking that and doing it. So or if the leadership says, which is what's happening exactly in our study right now, we have too many COVID sick people and we have limited visit slots. So all the preventive care is gone, and the leadership makes that decision. We're not doing that right now because we can't. We have access issues. So it makes it not happen. So there's certain things that you can see consistent patterns that if they're not there, there isn't success. So I do see some of that useful. That you know, you could call it something cute, like the 10 things that if they aren't there will make your project fail. You know, because if you don't have one of those 10 things, it's just not going to happen. I don't know. I'm seeing a lot going on in chat and I'm having trouble keeping up with this, but or do you feel like that's just chasing after stars and we're not going to get anywhere with that?
I think there are some really basic domains to consider. And so it was making me think they're not going to be able to take in a big complex theory like CFR. But maybe they can think about the high level domains of something like CFR. Like, is there an accommodating inner setting? And then I was also thinking about the COMB model or framework, where there's sort of 3 main components or domains to think about in predicting behavior. Number 1 is their capability. Is there an opportunity? And is there motivation? So do they know how? Do they want to? And do they have time to actually do the QI initiative, whatever it might be? And so starting with those really, core domains, whether it be this framework or something else, could be helpful.
What's the B part of that?
Behavior. It's the capability, opportunity, motivation predicts behavior.
Well, like Leif Solberg's model has that. It's similar. There's 3 components to it, which is, do you know how to do stuff in general? Do you want to do this thing? And do you have the resources and capability to put it all together? Just kind of looking through the chat. Anything else, Amy and Katy? I mean, we have about 15 more minutes to talk about this. What I have as notes so far is to encourage them to think about a framework for outcomes like re-aim so that they can have some level setting across projects rather than just all these very different outcomes. That there might be some basic domains that they can go to look for that, I don't know, I'm kind of picking up like some expectation setting, like things are really, really hard to do anything ever, and they're especially hard to do anything right now, given the COVID, I don't know.
Well, I mean, I don't mean to say that too much, but I guess I guess I would message back to them that you all could message back like, here's some recommendations, and really you all get to pick. There isn't a gold standard, and they get to pick what fits their goals. I think of the impact collaboratory as they try to increase pragmatic clinical trials that are non-pharmacologic interventions for dementia. They have picked the WRAPT framework, which is not one that any of us use, but they teach to it, and therefore we all use it as we apply.
So what else am I missing in my summary from what we've talked about?
I think it would be worthwhile to mention to them the concept that Russ mentioned, which is the rich get richer. So what are the unintended consequences of them imposing their bias of their perceived value when it really should be the eye of the beholder?
I think it's almost like the reason they came to you guys is because they're looking for evidence and they're trying to they're trying to think outside the box. And Russ or Jodi or Bethany or some of you more experienced people, I remember a comment when I took the TIDER training where somebody said, I'm going to oversimplify a little bit, but one of the biggest things we know in implementation science is the most successful projects tend to have multi-level stakeholder engagement. Mm-hmm. I feel like they cited a paper that reviewed some studies and showed that. And I wonder if that's the kind of thing they're looking for from asking you guys is, well, here's some evidence. If you have a project that hasn't engaged stakeholders at multiple levels, then that's going to be less likely to be a successful project. I've looked for that reference because that was a provocative statement. I don't know if it was one of those sort of glib comments or it was actually a reference statement. So it's a bit of a question to smarter people.
I don't know if any, go ahead. I don't have an answer. I'm not a smarter person and I don't have an answer either. I have a couple thoughts, but whoever was speaking, go ahead.
Yeah, Dan, I would tend to endorse that statement on the basis of, or back up that statement on the basis of all of the different, on the body of literature showing that multi-level interventions are good. And so I'm not sure I have necessarily anything to point you to in that regard. But certainly knowing that you have multi-stakeholder buy-in is important there. I also just wanted to point out that one of the big predictors that I've seen in terms of successful implementation is previous experience trying to implement something like that, whether or not it was successful. And so they need to take a little bit more of a long-term view that we've identified that X is an important problem and we tried it this way and it didn't work. But now we have some experience with that and we can try again and we can do something a different way. I mean, this QI is inherently iterative and you have to start somewhere. And so I don't think they want to not try something for fear of failing.
And I was going to reflect somewhat similar things. And one track I've been going on there, I'm having this pretty strong deja vu of it's been more at an individual level, but there is a whole history, at least in psychology, about trying to predict like graduate students to accept them, who's going to be successful. TIDER and others, you mentioned, Dan, have tried to deal with that and things. The only thing that holds up robustly is the people that are better off to begin with on every criteria. And that's what I'm concerned about, that are more successful in the past are much more likely to be successful. But from a program, is that the only criterion that you want? And I do think there's real danger of unintended consequences there. I mean, you're probably not ever going to end up working in chaotic, low resource settings that deal with the most challenged populations and things. They have constant staff turnover, they have things. So I think it is an issue. And in a way, it's almost analogous to grant proposals too, I think. About, again, there's a reason why there's a bias about people do reviewers, they end up funding, and agencies even more, they fund up those that have been successful before. And if your only criterion is probability of success, that's probably a reasonable one. If you want to be a cynic, it's probably not the best way if you want to grow or help other organizations or settings or those that maybe could most use it. So last thing I'll say, I don't mean to be a downer, but I think at least at the individual level, there's really pretty conclusive evidence of that, I think. So it kind of comes down to a values thing. That said, I don't know why, but my own gut level is that it's maybe an asymmetrical thing, that I think it's easier to predict failure than it is success. So there might be like some of the things you've talked about. I think if you don't have good stakeholder engagement or alignment priorities, you're pretty much guaranteed to fail. But because you have that, doesn't necessarily mean you are gonna succeed. So I don't know if there's checkpoints or something like a checklist. Or Jodi, I love your kind of QCA comparison. To me, that fits better, and I think maybe it would be more likely to predict than would a more traditional, particularly linear model or something that you're going to try and establish a predictive model.
We have a diagram on that, the cascade of implementation failure in the mental models paper. And then there's something very similar to that in the lung cancer screening paper around how re-aim can cascade into not working. So it's like, these are the things that, like, so in the mental model paper, it's something like, okay, you think something or your version of what an intervention should be or a success is different than mine. So therefore, we're starting off in a different place. And then we try to do something and it doesn't work very well because we're not understanding it similarly. And then it looks like it doesn't work. And then, you know, like you just get into this cascade of different colliding events that affect each other, and then it doesn't work. So I don't know. So that's another way to think about this. Sorry, my dog is, stop. The other place that I was going to go with this, stop. I'm sorry. But the other way that I was going to go with this is Don Niche has been sharing some videos from this organization from the UK. And it's essentially about complexity theory. And it's really about how all of these different forces intersect. And even if you start at a certain place and you have certain kind of, I don't know, domains that you're looking at, there's so many other intersecting things that you can end up in a, oh my gosh, end up in a different place. Stop. End up in a different place. And so this is Toby Lowe, if anybody of you are familiar, and this is maybe, we're almost out of time, but this might be a good future discussion, his premise is that many outcomes that we determine, such as, you know, improvements in X or Y, actually undermine what we're really, really wanting to do. And that it's really more about learning and well-being and growth and those things. So it's kind of what what you were putting in the comments here, Dan, about, you know, team improvement or whatever, rather than achieving some kind of outcome, which a lot of outcomes are not really serving the institution or the individuals involved. So you have to be careful with what you set as your outcomes. Like the example of, this is an educational example, I don't know if Laura's here today, but like trying to have students be tested on what they know according to a curriculum, then the teachers start teaching to the test, and then they miss out on a lot of other valuable other experiences that contribute to their well-being and their learning and growing. And a lot of things happen like that in healthcare too. So it's kind of like we can set this particular outcome, but maybe we accomplished a lot of other things. So I guess my mind goes there, is that it's not necessary. It's hard to show to funders, like, look at all the great things that we improved for patient outcomes, but it's just not that simple, I guess. What's the organization in the UK? I can find that and send that, not at the second, but I can. So there's also a group in South Africa. So there's the center in South Africa, and then there's this place in the UK. And I'll get it later. I can't remember. It's like the Center for Complex Well-Being, or like something like that. So I'll come up with it. Well, anything else in the last minute? Sounds like we don't have here's an answer for them. I saw that someone put organizational readiness. I think that hasn't been a very good predictor, is the problem. And there's more to it than that captures, but it's not a bad place to start. can we make sure to get the chat? Because I've been taking notes, but I'm not sure if I've got everything. So, okay. All right. I have to go to another meeting. I'm sorry. But wish us luck.
Good luck.
Okay.
I think you're on mute, Russ.
Oh, thank you, Dan. So Hillary told me the other day, it's been 94 weeks now. We've been into this and still can't figure out my my mute button. If she hasn't left yet, I was wondering, Amy T, from her experience with quality work and things, and I was wondering if there are other things that they've done. I vaguely remember IHI from decades ago when I interact with them had, I thought, some criteria or whatever that they would use before working at groups. I mean, one of them, of course, was that you'd pay them $20,000 or more. But other than that, you'd be motivated. But I thought they certainly have a huge amount of experience. I just wondered if you have anything comes to mind there.
No, I wasn't aware of that, but I could definitely reach out and see if they would share some of that experience and if what they were using was working.
Okay, well, anybody have one last idea to go there? I don't know. Does anybody want to counter or have anything else? Jodi had to leave, but on the organizational readiness to change, I guess my other thought about that, and it's not exactly the same, but the group, Greg Ahrens and colleagues, implementation climate measure. There's another group that has one now too, that I think might have a little better specific predictor for implementation outcomes. But again, I'm a little skeptical there's going to be any one magic scale here. I think like you've all said. Okay, well now for something different, and it's either Dan or Monty Python. I think they're going to be up.
might be more organized if he did it. Here, let me share my screen here. Oops, I pushed the share. I pushed the wrong button here. PowerPoint slide. Are you guys seeing the full screen there?
Yes, we can.
Okay, now let me just play with the faces here so I can have you guys on my other screen. There we go. I've kind of, after 94 weeks, I finally learned how I like Zoom to be on my computer when I present. So I'm going to talk about an R01 resubmission, not even a resubmission. I already resubmitted it and it didn't get funded again. So I'm going to go in as a new submission. I was thinking February, but my December kind of got away from me with COVID. And then I was co-PIing this with Laura Scherer, and her life has obviously turned upside down. So we're shooting to put this in June, which is fine because I don't have all my ducks in a row yet. This is my last slide, but it's also my first slide. I sent the reviewer comments so you'd have them, but these are the ones I really need some help focusing on. Reviewer 1 said things like, it's not clear how digitation would advance the field of shared decision-making. It's the innovation significance kind of comments that I need the brain power in. If further digitation is the reason DAs are not being widely implemented, it's not clear how the proposal seeks to advance the field of implementation science. It's not clear how this will be different than other current effectiveness implementation trials. It's like reviewer 1, and if you see our scores, they weren't terrible. Even reviewer 2 really liked us. And some of the approach things I can actually fix, but this sort of significance of the whole enchilada is where I'm struggling. So I kind of feel like I need to blow things up a little bit. Reviewer 3 said something similar. Trial design planning with clinician champions is not innovative. It has been used in many studies before. So they're just not seeing some innovation. So I'm going to spend about 10 minutes, since I know you're not all cardiologists, just giving a tiny bit of background on this decision, because I think that context matters as we dive back in. I also sent you the aims of the prior R01. I haven't written new aims yet because I'm still struggling on where to go. I presented to our our shared decision-making group last week and got some great ideas. I've talked with Russ, I've talked with Larry, I've talked to a few people. And I'm starting to come down on how I need to change the trial away from maybe a step wedge design to maybe clustered around the physician. But anyway, let me just give you a little context. So this is an old trial from 2005, but this is the benefit of an implanted defibrillator, a little pacemaker looking thing, sits under the skin, senses dangerous rhythms and shocks people if it senses that rhythm. It's a big decision. It's really common. You know, we're doing 100,000 of them a year. About 1 million people in the country have one of these things. They were originally designed for people like the person who passes out at the airport of an arrhythmia, but now they're getting used just in people with heart failure who are at high risk for arrhythmia but have never had one. Which that's how me as the geriatrician gets interested into this. Because this happens to all of my older patients where, oh, they're high risk, we need to do this to them. And you don't have to do these things to them. That's what we in geriatrics kind of push back on. Well, is it right for them? Is it consistent with their goals? What about their competing morbidities? This is the whole art of geriatrics that I actually love. And so that's how I get into this. But that's the population that these are getting used on, is a lot of older adults. So they're beneficial. Over 5 years, these have a 7% absolute risk reduction in mortality. This is all cause mortality. Like they say, these things could potentially prolong lives. And so I don't want to come across as a nihilist. For some people, these are right. I have 3 small kids. I'd get a defibrillator if I had heart failure, but I may not make the same decision when I'm 85 and they're kind of sick of me. And my wife has died, or I have dementia. You know, things change in life, and that's where this gets interesting. They have a host of downsides too. A couple that I'll note. There are case series of people getting things, even post-traumatic stress disorder from getting shocked. I had a patient who would wake up every night with a nightmare that he just got shocked. And they would go look at his device and he hadn't gotten shocked. It was just his nightmare. But he would call the clinic every day. And it turns out that's a recurrent nightmares is a cardinal symptom of PTSD. And he was also very thankful he had it, because his shock was a life-prolonging shock. And luckily, over about 6 months, the nightmare sort of faded. But, you know, these things are not for everybody. There are some people where that would be so morbid, it's not worth it. Also, this is better now, but people would not turn these things off because they didn't know they could. And then they go to hospice from dying of some other cause like cancer. And then they would get to the very end, get a lethal arrhythmia, and they'd start getting shocked on their deathbed while their family is standing vigil. And so now this wonderful therapy it couldn't be much more harmful than that in terms of family bereavement and grief. So there are things that there are downsides to these things. And I won't go through all these because it's not that important. But this is the big thing that I want docs to start talking about, is really assessing patients' values. You know, this is a model from JAMA, patterns of decline. We stole this from the model. And there were actually 4 patterns of decline. You could be really healthy and die suddenly, be really healthy, get cancer and die quickly. This is the sort of chronic disease pattern of decline. And then this is sort of where defibrillators fit in. And defibrillators only treat this one. So basically, you take somebody who would have died suddenly, and now they're living with a progressive illness. At least the majority of these patients with heart failure who are the majority of people with defibrillators. There's obviously the young soccer player who has the weird genetic heart condition where defibrillators are truly a niche life-saving therapy. But it's different, and they don't necessarily have a chronic illness otherwise, or a progressive illness, I should say. But this is a quote from a qualitative study, and this is a conversation that I don't think is happening. This guy was a former hospital chaplain, so he was a savvy patient and knew the system, and he decided not to get a defibrillator. He said, going into my decision is the fact that I can't work because of my condition. I can't work at the hospital. I can't work at the church. My life is sitting here watching TV. To take a defibrillator would just lengthen a process I don't really want lengthened. And I think this is not the way that even people who decline don't say stuff like this. They say things like, oh, that data didn't apply to me, or I'm not at high risk. Like, they're just really uninformed. And our docs having this level of discussion with patients to find out their values. This is a big survey we did through the American College of Cardiology, but we were trying to ask that question: do docs care about sort of patients' understanding and their preferences? And so because there's a huge social acceptability bias around that, we hid those in a list and asked which of the following factors, or how important are these in your recommendations? And we had them score them from 0 to 4. And you see mortality and guidelines were up near 4 out of 4. Patients' preferences, 3 out of 4. Patients' knowledge, 2.2 out of 4. So docs aren't seeing these things as important. And I would argue there is a right answer here. We should have high-level evidence, and you should also highly prioritize the patient's understanding and preferences. At least that's sort of the moral argument I make. And then here's a quote from the cardiologists, and this is why I wanted to give a little background, because these are the people I want to intervene upon in this R01. And this is how they think. And I have empathy for this thinking. And you see, I call it beneficence paternalism. This was a salaried doc. This is a doc who actually, his day is better if he puts in fewer ICDs. And he said this: I think my biggest concern is if I convey the risk to them too strongly, they will choose or make an unwise decision and not proceed with therapy. And this is what Jodi wrote this paper on mental models that I really like. But this is this mental model that we kind of have to overcome in our implementation. So, you know, this isn't, I like this cartoon, I just kept it for fun, but this isn't shared decision making. It's not just about throwing options at patients. It's really about this collaborative bringing people together. And my favorite definition of shared decision making is still a really old one, which is a meeting between experts. And I like it because you're acknowledging that that patient is an expert as well as the clinician. So this is, you can hear the argument I make on why the doc should do this. And I'm trying to figure out how to turn this into some sort of intervention. And I've tried in my current trial, and I'll tell you the challenges we've been having. But here's how we did it in one of our tools, this trade-off I mentioned, that I really want docs to start having that values discussion with patients. And in the video, it plays really nicely because we have one patient saying one thing and one patient saying the other. And then our narrator, who's an electrophysiologist, comes back and says, now that you've heard these options, what's right for you? And that's in the psychology world, at least in a couple of papers, that's called an Imagine Futures exercise. We try and get people to imagine a future state in one of these two. And sometimes narratives can help with that imagined future and maybe overcome errors in effective forecasting, something we have a hard time figuring out how we're going to feel as humans. We have a hard time figuring out how we're going to feel in future health states. It's just something we don't do well in the decisions that we make. So you can see these quotes at the bottom. Somebody might choose path 1 and get an ICD, and they might say something like, I'm not ready to die. I have so much I'm staying alive for. Even if it means getting shocked, I'm willing to do anything to help me live longer. Or I've lived a good life. The idea of dying quickly sounds like a painless way to go. I've always said I hope to die in my sleep. Going through surgery and getting shocked is not the kind of thing I want. So we say this stuff in our tools, but I don't think this is the conversation that's happening in the encounter with the doc. And I think we can say it all day long on a piece of paper or in a video, but if I don't influence that conversation, I don't really get anywhere. So yeah, and I was just going to make the point, we say this in the video. So a couple sort of national things. The guidelines recommend shared decision-making as a class 1 recommendation. These are ACC, HRS. For people getting defibrillators at risk of sudden death, clinicians should adopt a shared decision-making approach in which decisions are based not just on evidence, but also on goals, preferences, and values. So they said this exact thing that I'm trying to get them to do. And further, there's a mandate, Medicare mandated shared decision-making, saying you need to have an evidence-based tool on ICDs as part of your implantation. So we have societal guidelines and policies supporting that docs need to do this. And in that mandate, they actually referenced our website. This is an old graph. I couldn't find more recent stuff to show you, but you know, we're getting 500 hits a week on our website because of this mandate. So people are using this and doing it. And we also have it freely downloadable. So we don't know how many people downloaded it and are printing up paper copies on their own. But implementation of these decision aids is really hard. We have a current R01 where we have implemented at 6 sites. I'm going to tell you very briefly about that. You know, it's hard to know who's going to deliver it, how will it be delivered, and then different decisions are different. And when the decision aid, like when is that person actually in their head making a decision? it's really hard to intervene at that time. For me, I'm a perseverator, and it's often I lay down in bed, everything's quiet, and then all of a sudden I start weighing pros and cons of something, and then I'm up for an hour. But that's when a decision aid might be helpful, because I'm sitting there wrestling with it. And so getting a tool like this in their hands when they need it is hard. So our prior trial, this Decide ICD, which was funded by Citrus, was a 6-site step wedge design. We're just finished our data collection and we're getting ready to analyze. We're doing some data cleaning, found a couple coding errors. So we're at that phase. We're very close to having some data to show. But this trial is fully contaminated. It has 2 huge problems. The first secular trend is that Medicare mandate happened right here. So our entire control group now had a mandate to use decision aids when they weren't supposed to. And we actually had a call with CMS asking if they would let us out of this, and they wouldn't. But they were thoughtful about it. There were 6 people on the call and said, you know, you've really challenged us here. And when we write these future mandates, we need to put some language in there so that our mandate doesn't hurt ongoing research. We didn't even think about it. But if we were to fix it, we'd have to go through a full public comment period, and we can't right now. We don't have the bandwidth, and we can't do that. But they were thoughtful. I actually was impressed that they read our full proposal and really considered it. But then they said no, so that was a bummer. And then the last 2 sites, we had this, I don't know if you guys know, there's this virus called COVID, and it happened right about here. And so our last 2 sites, the implementation didn't go well. We didn't get to go do anything on site. And the last 2 sites really had terrible reach now that we're looking at the data. They just didn't do it. And I don't know, they're busy. A lot of their cardiologists were the ones pulled in to do extra shifts. I mean, I don't know what all the factors were, but our implementation didn't go well. So we have sort of an a priori on treatment analysis. So we'll look at, of those who use the decision aid, what was the effect? But you know, some of our outcomes are really sort of hampered by this. So I've been writing this next trial knowing that whether this trial is positive or negative, we still need to do more work because there's a mandate, there's guidelines. If this is a negative trial, then we need to revamp things. If it's a positive trial, then we need to figure out still how to get this so it's not just a checkbox in other places, because we're already hearing qualitative work that at other sites, this is not, you know, sites are just using it so that they can meet the mandate so they don't get audited. And they're not, I don't think they're actually doing anything. So this is also in your email. I sent the aims of the last trial. So what I still think this is the work that needs to be done, but I'm not framing it right. And it's not passing the review process, and I really want it to. So I think we need to refine the decision aid. The docs keep telling me they don't like that I present that 2005 trial in the decision aids. They want to be able to tailor it to the individual. There's a big difference between the 50-year-old with ischemic heart failure versus the 85-year-old with non-ischemic heart failure and lots of comorbidities. So I don't know if tailored statistics help patients make better decisions, but I do think they help docs buy into it. And I'm definitely hearing this over and over. And even at some of our sites where we implemented, one of the docs in our qualitative interviews said, yeah, I don't use yours because I don't like the SCUD heft data. So I go to this website and I use this calculator and I present these statistics. And it was a nice interview of a guy who wasn't against shared decision making, I would say. He just really wanted things tailored. And then if we can make this more electronic so that there are more ways sites could, right now we have it freely available online, but if we have a tailored approach, we'd like to design a few ways where it could either be accessed through the EHR or at least accessed externally and then brought the results brought into the EHR the way the Mayo clinics do. We were going to give sites a few options there so that they could adapt to their local setting. I don't really care how they do it. I just want to make it as easy. I want to give them options and do some work working through troubleshooting it so that when they go to implement, it's easier. So that was the aim 1. Then aim 2 was, I want to get in, this is where Laura was helping, use some of the patient's stories and the things I've heard from patients about how things didn't go well or they didn't get what they want, and use those stories as part of our strategy, because this is now that mental model piece. I do think one of the big barriers is overcoming that belief that I don't want to tell them the risks because I don't want them to make a bad decision. Well, let me let you hear from some patients. Could I design some strategy that motivates you to do that? And so, but I said we designed that strategy in AIM-2 using patients' interviews and stories. And that it wasn't seen, you can see the reviews is what's innovative here. Nothing's innovative. And I don't even know if that's going to work. And then we were going to do a stepwise design at 6 sites again. I think we're going to blow that up. I've already kind of decided based on all the approach comments that I think with the same 6 sites, depending on the numbers, if I did a clinician level clustered trial where the control clinicians are using the static decision tools as is, and the intervention clinicians get this updated tool and a little more communication training, that we could then test that again. But then I think another problem is I'm doing 2 things. It's not reductionist enough for an NIH panel, and that I'm trying to change the tool and change the strategy at the same time. And that's confusing. And I see that, and I agree with that. And Laura said the same thing. And so I'm open to ideas, but I just wanted to present here to see what could I do really to overcome this concern that it's not advancing the field. And I have some ideas, but I won't put those out there just yet and just see where the discussion goes. But this is where I'd love any comments you have about any aspect of it are welcome. I'm just going to start taking notes, but I need to, if I'm going to really write new aims, I got to come down with something. Am I going to put my flag in the ground on contextual assessments or adaptation assessments or something that's actually going to advance the field beyond just defibrillator shared decision making? Oh, and another contextual piece, the NHLBI, I had a call with my project officer, Sue Sharrow. They're going to they have an R01 right now that's implementation of shared decision making in NHLBS diseases. That's going away in May. So I'm going to have to apply to just the parent D&I R01, which they still have language in there that they want shared decision making, or Sue said the next version will have that. She thinks and hopes. But it's going to just go to the generic D&I parent R01. So I really need to push the science in that space. I just don't know what to do. I don't know what's going to give me the best bang for my buck there. So that's why I thought I'd bring it to the group.
Dan, are you considering changing study sections?
Away from SIHH?
Mm-hmm.
I haven't. One of the challenges there is the NHLBI doesn't have just a generic parent R01 anymore. You have to have an R01 with the NOCs. Oh. And so you can do the R31, R63, R31, but that's a single site clinical trial. If you do a multi-site clinical trial, it has to fit one of their other sort of funding priority areas. You can't just do a generic parent R01 anymore. And they don't have R21s either to kind of peel off AIM-1 or AIM-2 as an option. So I'm trying that D&I R01 feels like the best one, but I could be wrong.
Yeah, I guess that would be a limitation if you have to go through that institute as well. But there's an interdisciplinary clinical care and specialty care settings study section. And it almost seems like if you could get a whole new audience, they might see it through a different lens, which I've seen happen, many times. They might not have these same criticisms. But you'd have to go through a different institute, it sounds like, and I can see why you're going through NHLBI. Could you go through aging, NIA, and then go through that particular study section and just go through the parent R01 mechanism?
Yeah, maybe. One of my friends at Harvard, Karen Sepuka, does a lot of shared decision-making work. We were a site for her R01 for TAVR that went through that specialty section, the interdisciplinary and specialty care section. And they said things like, I don't think we should even be doing shared decision-making. There's no evidence that this improves clinical outcomes. Like right. They were sort of awful.
Wow.
So we actually had a call trying to figure out how to get her grant framed more around the D&I, because the D&I section generally has been quite open to shared decision-making and patient-centered care, sort of on the philosophical perspective. And reading through some of their comments here, they liked that. They liked the team. They felt some of it was important. They just didn't think I did anything to advance the science.
Yeah, I wonder, and how long ago was that? I mean, study sections turn over and the composition changes every 3 years in terms of,
These comments were from the October section.
Oh, okay, okay. The other one that I don't think is quite as good of a fit, but I don't know, is the health services quality and effectiveness. And it says, yeah, I don't know if you're familiar with that one, but it does say access, receipt, utilization of services, cost effectiveness, comparative effectiveness in a variety of different settings. I don't know, again, I've been putting I imagine a lot of people on this call know you can put the abstract of the NIH or the specific aims into the ART tool and see what's recommended, but then push it with the right wording in one direction or the other. I know, just a thought, because my experience has been sometimes I don't have to change the grant that much. I just need a different audience.
Yeah.
Different viewpoint. But if you just got that shared decision-making feedback from that other study section, that doesn't bode well for that particular fit.
Yeah. Well, the interdisciplinary, the HSQE, I don't know much about them as far as how they react to this kind of stuff. I think that's one of the HSOD orphans, if I remember.
Yeah, it was part of the restructuring, I think, right? This is one of the new ones, I think, but.
Yeah, it's a good reminder. I should go back and look at ARC too and see where they're at on some of this stuff. I haven't actually perused there with the idea that I'm rewriting this now. NHL has been generally pretty good to me on this stuff, so I've kind of tried to push with them.
Yeah, I asked ARC the other day because we're working on this shared decision-making grant, and they actually have something that it's called Disseminating and Implementing Patient-Centered Outcomes Research Evidence into Practice Through Interoperable Clinical Decision Support. And it's a mechanism that allows for more than the $400,000 cap that includes indirects, that is usually a limitation of ARC. I asked specifically for a cluster randomized trial, like if our NIH trial doesn't work, could I send it to ARC and what are the options? And this one just opened in January, and it's open through, I think, at least another year and a half, May of 2023, I think I saw. And it's up to $1 million in directs, or up to $1 million a year, which includes the indirects for ARC.
Wow.
It may be worth looking at because it seems like it could be a good fit for you.
Yeah.
I'll forward you the link and the information on it.
That's great, Jen. If you could have it at your fingertips, if you could put that in chat, that would be great.
Sure.
And I just wanted to, some of you know this is Russ's broken record, but I just want to strongly second your notion about talking to at least a couple different program officers at different places. Most of our applications can go, at least a couple places these days. And I just have found it really valuable throughout my career. Even if you don't end up going there at all, or they tell you it's not a fit, you almost always get some helpful feedback. So I just like to put a strong second to that.
Yeah.
They tend to know the culture of the study sections too. Like they tend to have a sense of the reading between the lines kind of aspects that you can't get on the websites.
Yep.
Yeah, I'll look at that ARC call. That's good. And I just actually perused the comments real quick too. And Bethany, I think it was your question, Bethany. I've lost but about, is this effectiveness or is it implementation? And honestly, it just truly is both. It's really a hybrid, because it's so hard to do shared decision-making is already a group intervention. These decision aids, when you just do these tightly controlled efficacy trials, they always help. They always improve knowledge. Patients come in with nothing. You do a decision aid and it goes up. That's the problem with the Cochrane review. We have a Cochrane review of 110 trials that show decision aids are great, and then nobody's using them. And so that's what pushed me into this group actually, is how do we actually make something so I try to design with the idea of getting something that's useful, and I break rules in that process because the docs say, oh, if you do that theory-based IPDAS thing, I'm not showing it to my patients. If you do it this way, then I'll use it,
So the problem you're trying to address is this notion of acceptability. It sounds like that there's this basic implementation problem around acceptability. You can work on the feasibility, you have the implementation process down. That doesn't seem to be the problem. It's that you have this chunk of people who say, this doesn't work for me. I'm not even going to try to use it, because there's this fundamental problem of, lack of individualization or personalization. And so this study is designed to address that particular critique that you've gotten, and your primary outcome is we're going to enhance that acceptability or something to that effect.
I like a lot of what you just said, because that is a lot of what I feel like I butt up against, is trying to make this thing acceptable. I wonder if that'd be a framing for the grant. At least, I mean, yeah, I would love to frame it around that as like, without them thinking that that is just some proximal outcome. That is, because that is the big barrier of how do we, it's acceptability, and it's also the acceptability of a patient saying no to therapy. Like, that's another reason why it's not acceptable, is that, well, I want my patient to get it, so I don't want to scare him with all these statistics, because this could help him live longer. Like, I heard that was a theme, because we heard it from so many docs. And I'll tell you, I have felt that with a couple patients too. I had a young patient, cancer, who was refusing treatment because his buddy didn't do well with chemo. And I was like, God, you're just not informed. And he refused to see the oncologist, and he ends up getting pancreatitis, and then he wanted chemo, and then it was too late. And he died. And I still feel bad about that. I mean, I don't know if I feel bad about it, but I still wonder if he really was making the decisions that were right for him. I talked to him as much as I could, but I was feeling that paternalism. I was feeling it. Like, I wanted to sell, at least go talk to them, at least go see what they have to offer, and I feel like that is that acceptability piece. Like, well, if they do shared decision, I have all these quotes. There's an email that a doc sent me after the mandate and said, hey, my whole 30-year career, I've never had patients decline a defibrillator. And since I've been using your tool, I've had 2 patients tell me they don't want one. And he was angry. This was like negative feedback. Right.
Wow.
I remember, I think it was Chris who said, well, maybe we should go look at the last 30 years of his practice and see how his patients feel about what he's done to them.
Yeah.
Because, but, and I have a lot of quotes like that I could put in here about how this is just not acceptable in some ways.
And so there's probably multiple things you can do to enhance acceptability. And so one of them is kind of adjusting expectations, that yes, this might mean that some patients will decline this treatment. And how do you present that or frame that in a positive way? And it sounds like you have a number of other sort of qualitative types of feedback that you've gotten that you can really address. It's almost like intervention mapping, implementation mapping that needs to be done to figure out, well, what are the features of the tool itself and of the implementation strategy? What's the education? What's the framing? What's the strategy for enhancing buy-in that you need to enhance what you already have? So you have this you have your existing tool, you have your existing implementation strategy, and now you need this sort of enhanced version of it that is developed, through intervention mapping or user-centered design, or however you want to approach it. And so, can you address these types of acceptability challenges that I am sure are not unique to this particular decision support tool? It's probably a general problem in the field. And so is there innovation in advancing the field of D&I? Well, is there some sort of generalizable problem that you can address in implementing clinical decision tools?
Yeah. Well, I was just going to ask that generalizable problem that I could address. I was just going to ask, do you think framing around acceptability is that way to get over this hump from these comments here of it's not clear how this advances the field? Because I like the framing. The Sue Share was recommending framing it all around precision and putting it under that umbrella. But I actually think getting the precision piece actually is one subset of the acceptability piece. And I like that acceptability umbrella a lot.
I
It
do
depends on
too.
the reviewer. Sorry, go ahead, Russ.
As always, it does. I was going to go where Laura did too. I agree with what Bethany is saying, and from our frame, and maybe if it goes to the D&I study section, I think that's a good one. But I was going to suggest doubling down for, this is NIH after all, about going to, quote, precision shared decision making. I mean, everything's about precision, and that brings in, the quote personalization there. And what I was wondering about that is, you've heard this from the docs. Do you hear that at all from the patients? I'm just trying to think from different stakeholders that how do I know this applies to me? Or do they pretty much just accept when they see the figures?
They accept when they see the figures, but in people who've looked at that, there's been a few. Once patients know there's a personalized option, then something about the personalized option doesn't really change their decisions, it looks like, but makes them trust the data more.
Okay.
So just being told, oh yeah, this is based on your characteristics.
Yeah.
Whatever that means. Oh, you're a man. Is it just like you're a man or a woman? Is that your characteristics? Because it's still squishy stuff. And it's a model, so it's never going to be perfect. But it did, in a couple things I've seen presented at SMDM and such, the personalization made people trust the data more.
Yeah.
It didn't necessarily change the decision. That was more about their values and goals, and whether it was 9 out of 100 or 7 out of 100 didn't seem to matter. But being told that this was based on your data seemed to have some effect.
Mm-hmm.
In something. So I think it might, but I think the docs is where I hear a lot of that feedback. And I don't know for the docs if it's just a nice way to say, hey, I don't like shared decision making. And if I give them the precision tool, it still is not going to matter.
Yeah.
Like I have that hypothesis too, that it's just a socially acceptable barrier to tell me, oh, your tool is not precise. Yeah. Rather than, I don't like this. I do this fine on my own. Thank you very much. Mm-hmm.
It's like the barrier of, I don't have time. Just tell me you don't want to.
Yeah. I mean, it's this work here, we've had this discussion in the D&I meeting a lot about making sure that the group of people want to do the intervention before you implement. And I always push back because everything I do, the docs don't want to do. And so if I use that as a metric for moving forward, I wouldn't do any of this work because the docs don't want to do this. And the ones that do, are probably like my colleague, Paul Verosi, and probably already is doing a pretty good job at this without a decision aid. The docs that aren't doing a good job at this are the same docs that probably need it the most.
But Dan, let me just push you a little bit from what I've heard you say over the years, and maybe try and reframe it and what Bethany's and you have been talking about accessibility. Is it that they don't want to do it, or is it, as I thought taught me, that they think they're already doing it?
There's that too.
Oh, why do I need all this? I'm sure I already do it. I'm totally patient-centered. I do a great job of this. And if so, that's a different problem rather than I don't want to do this,
Yes. Well, yes. And I think I'm saying a little bit the same thing. It's actually more accurate the way you said it.
Yeah.
Doc, so I already have good patient-centered discussions. I don't need your tool. That's probably more what I hear.
Yeah.
If people are really being honest with me. Chris, jump in here. Chris has been doing a lot of the qualitative work. If I misspeak on things you've heard, go ahead and jump in. I'm not putting you on the spot, Chris. I don't feel like you have.
No, not at all. I was just actually typing in the chat, but I think it's hard because doing shared decision making with air quotes around that is hard to characterize when it can actually be a lot of different things. I think a lot of the times we boil it down to, are you willing to use a decision aid in support of your conversation with the patient? But that it doesn't necessarily mean that. I do think that Bethany is exactly right in the sense that a lot of the reasons that we hear are excuses in the sense that, I don't want to do this, or I think I already do this in my way, which is better than what you're proposing for me. So I'll just say that it's really about something that you can't argue about. And the thing that gets left out, and I think what this is attempting to the gap this is attempting to address is this values clarification, right? So like docs probably do a pretty good job most of the time in educating patients about risks and benefits. I mean, particularly benefits, but risks too a lot of the time. It's where that falls by the wayside is the circumstance where there's a patient for whom this is probably a really good idea from the clinician standpoint, and they worry about the going down the track of having a conversation about what's important to you, if there's any possibility that that'll turn the patient off to this therapy that you yourself believe to be a good thing for them.
Yeah. I mean, I wondered, so do you think, I just saw Russ is coming, about 5 minutes left, you know, so if I was to go and rewrite these aims with something, when started them out with something like, sometimes when we implement things, the docs don't want it, but that doesn't mean we shouldn't implement it. And here is an example: defibrillators and shared decision making. But we're really going to push the science on trying to overcome clinician mental models or making interventions more acceptable to clinicians. And we're going to propose some strategies here and test whether these strategies helped improve the acceptability of an intervention for clinicians who variably want this intervention. You know, I don't know if that's a good framing that then all of a sudden feels like it's advancing, it's being innovative in the implementation science space. Yeah, I see your eyes, Bethany. I kind of have the same reaction. Like, I feel like if I don't go in and say, I'm testing this strategy with these 2 arms and this gets the strategy and this doesn't. Yeah. I mean, if that way, if I kind of, and so I presented this to my patient panel too, and they're like, one of the patients was like, never underestimate the power of a patient's story. And we could make a little video of a montage of patients who've had decisions that didn't go well, which I think docs, for me, that would be influential. But I don't know. And then test, is that influential? The problem is unless I have a 2x2 design, then the refining of the decision aid and the precision and tailoring gets a little messed up, and it's not reductionist enough to just isolate that one effect for the grant.
Well, 2x2 could be old tool, old implementation strategy.
Yeah.
And new tool, new implementation strategy. And then you'd have your 4x4 design, because you're crossing your adapted tool and your adapted implementation strategy. And your adapted implementation strategy could include this, lovely patient story. And the new tool has the personalization component. And so is there any circumstance under which you can move the needle on acceptability of that, getting someone to do something that they really kind of don't want to do? I don't know. It's sort of I'm thinking about myself as a reviewer, and I don't know. I think one day I might decide, really, it's really just about acceptability. Haven't we been there, done that in behavior change? But then another day I'd think, yes, you've really, figured out where the implementation barrier is, and you're homing in on that. I think if you can, it would be super elegant to say we are enhancing acceptability. You are an excellent grant writer. I think you can definitely do it, but you're going to have to thread that needle to convince them that this is the problem.
And will it help to have your data, Dan? I mean, it sounds like you almost have data from the first trial.
We definitely will have a lot of data by June. That's going to help. I was worried writing this R1 last year. I thought that was going to be the biggest reason we fell down. And it was a comment. It was one of our comments, but it's not a huge one. I think people kind of see that this is going to continue regardless. But I think that'll help me. I think there's a lot of things that'll help me.
That might, like, when you go through all your data and you realize which sites were successful and why, that might ultimately help you reframe the strategy you're taking, and you would have then a leg to stand on that this is new and different, because one of my X number of sites or 5 of my X number of sites did this and it was clearly more successful.
Yeah.
And I think that also brings up to me, Dan, I was going to say before I heard that even, but I think doubly so now with Jen's comment and where you ended up with is context. And I mean, I think that story you started out telling us about first the context of the mandate, then the context of COVID gives you all more. But I think the study section is going to want to see something, a conceptualization and probably a model. And you might even try out before you just go by default to PRISM, you might think about normalization process theory or something else for that. But I think tying that into context and trying to understand that is would help too.
Yeah.
The other thing, Dan, the more you can link it to generalizability to other populations and other scenarios, which you probably already have, the more they'll see it as not just this one little niche. We're going to solve this problem for this small percentage of patients, and that might help as well.
Yeah. Well, this was awesome, everybody. I just noticed that it's 4 o'clock. I don't want to keep people over. Yeah. So my next step now, I've kind of presented to all the groups I'm presenting to is to write some aims, and at least some of you, Chris and Russ in particular, we'll see versions of these aims. But this is helpful because this is what I want to be doing. I just don't quite know how to frame it. So I think I really like that acceptability comment, Bethany, and running with that. And I'll look at some of these other funders too. So I got a lot of great feedback today. So thank you all.
Great. Thank you. Good talking to everybody. No meeting for this group next week, but we do meet on the 1st of February, I think. Okay. Have a good one. Take care, everybody.